the course, and we break for the summer. And then the second year starts up again in September. And the module we'll start with in September is the substance use and addiction module. So this will be the last time we see you here until the fall. I'm not going to get into a long formal introduction. If I did a formal academic introduction, we would be here quite a long time introducing Dr. Bernstein, and Dr. Quealy is catching up fast. So to say that, just very simply, I think the content, what we're going to talk about today, we really want you to sort of use that to sort of challenge the notion of what some of these very early well child checks are about, and put these in a sort of a behavioral framework in a very different way than you may have thought about them for quite a long time. I also want to point out today is kind of a milestone. This is our first international webinar. Dr. Bernstein is joining us from Trinidad. So we're using the magic of technology. Fortunately, I don't think it's a huge time difference, but somewhat. But welcome to our first international learning community webinar. And without further ado, Quealy is going to kick it off.
Great. I'm going to adjust the microphone from. So like Jonah said, we're going to be talking today about the well child visit. I think there's a few logistical slides we have to run through. Jane and I have no financial relationships and get no money at all from any of these talks, just so you guys are aware. Jonah, do you need to go over this? You guys already know this, the logistics of these details.
Yeah. Just to remind people, we're winding down this session, and if you haven't done your coursework, I don't know the exact deadline date. I know it's in early August. So if you haven't started or done your project, I think now's a good time to do that. And you can check with any of us for more details about that. This is how, this is all information you should guys be familiar with. We've presented before to you. And you'll get the slides so you can see this in detail, but it just shows the various credits you earn. And without further ado.
Okay. I'm too short. I'll sit in the fancy chair. Oh, that's even worse. Okay, I'll just be short. All right, so who are we? Jane, do you want to introduce yourself?
Well, as you can see, can everyone hear me?
Yes.
I am a developmental neuropsychologist, and my primary interest throughout the years has actually been in clinical teaching. So I like to say that of the team at Children's Hospital, I'm the one who is still what you might call the generalist. Everybody else seems to have fixated on specific disorders, generalist in that sense. I am indeed in Trinidad. I have fixed myself up in a air-conditioned room with minimal lighting so that you are not bugged by shrieking birds and other strange noises that are characteristic in this setting. Here I do work with preschoolers, do some evaluation of school-age kids, and intermittently work with a school that has a population of young people with developmental disabilities.
Great. So I'm the other speaker, Jennifer Quealy. I'm also a developmental neuropsychologist. I work on the main campus full-time, and I have 17 areas of specialty in contrast to Jane. So I work half-time in our spina bifida center. I work a lot with the complex patients that come through Children's Hospital. I do a lot on transition planning, guardianship, things like that. But I also work a lot with infants and toddlers through our spina bifida center. So I have a developmental program where I track development in those kids very closely. I also happen to be the mother of a 6- and 8-year-old, and parts of aspects of this talk, especially my trauma of going through some of the well child visits, will come from that perspective as a parent as opposed to a clinician. So I wanted to get a sense, I know this is kind of hard with all the remote sites, of who you guys are, where you're working, what kind of a practice, how big the practices are, so that I have a better sense of who, Jane and I have a better sense of who we're talking to today. if you have a mic to.
Hi, I'm Allie Robbins. I work at Holyoke Pediatrics with two other people here, which is a pretty big practice. We have 16-ish providers, and we have a site in Holyoke and a site in South Hadley, and it's a quite diverse patient population with big range of patient population.
Okay.
I'm Jenny Solander. We're from Amherst Pediatrics. Our other provider that's participating couldn't make it today, but we have 4 MDs, myself, and then 1 per diem provider.
Okay.
I couldn't tell you patient load wise, but medium-sized practice.
That's okay. I think sometimes the practices with 1 MD and the part-time nurse are very different than the practices that have the 16 MDs and people are working at midnight.
Hi, I'm Hannah Alcall. Good morning. I practice out of Chicopee, Massachusetts with Fairview Pediatrics. We have 4 providers in our office, all MDs. 2 of us are part-time and the other 2 are full-time. And we're happy to be part of the PPOC.
Great.
Thank you.
You guys said.
Good morning, I'm Amy Casper. I'm a physician at Pediatric and Adolescent Medicine in Wilbraham. We are a 8-physician nurse practitioner group split between 2 offices. So that's
Great. Thank you.
I don't know what order we're going in. I'm Victoria Pillard. I work at Holyoke Pediatrics. A number of my colleagues are in the room. In Northampton, we have 10 physicians and 3 nurse practitioners. It's changing rapidly. So more than that, I believe, actually.
Okay.
I'm Rob Peskin. This row is from Pediatric Associates of Hampden County. We have offices in Westfield as well as West Springfield, and we're a 13 provider group.
Okay. Great. Is anyone else online that would like to, besides Victoria?
Go around in Brookline if that's okay.
Yes, that'd be great.
I'm Vanessa Briscoe, and I started my own practice after being at Children's for a good 15 years, and I'm joined by Mary Sabatino, nurse practitioner. So it's the 2 of us, a small practice in Newton.
Great.
I'm Allie Stokowski. I'm a behavioral health clinician at Longwood Pediatrics, and I'm here with Dr. Clarity, who's also from Longwood Pediatrics, and we have 11 providers.
We have 11.
We're not sure. There's a lot of us.
Nurse practitioners.
And 2
Okay.
mental health providers, I guess.
Great.
Full-time, yeah.
I have a question. That the gentleman who said they had a 13 provider group, I'm sorry, I didn't catch your name in time. When you say you have a 13 provider group, what's the provider mix?
So it's currently
I think we have 10 or 11 doctors. I can't.
Sorry, there's it's Pediatric Associates of Hampden County. It's currently 11 docs and 2 nurse practitioners, and soon to be 10 and 3, just because of some personnel changes.
We're also getting information on the chat for those of you who haven't noticed it.
And I want to add for this group, they have a behavioral health provider as well, as many of the other groups that have spoken.
Great. Was there anyone else in Brookline?
nope, that's it for us.
Okay. All right. I noticed Scott and Jessica are still muted. We'll leave them alone unless you guys want to tell us. Okay, maybe we just got them napping.
Scott's on the chat. 5 MDs and a BH.
Okay, great. I can't see the chat from where I am.
Oh, okay.
Okay. All right. So as Jonah said, we've done this talk quite a few times. And what we've realized is that this could be a day-long workshop on how to work with kids of different developmental age groups, especially if we started in early childhood and went all the way through adolescence. But we're going to focus today on early childhood in the effort of saving time. Okay. So these were the practices we were waiting on. So I want you guys to think to yourself and try to answer these questions. So do you feel like there's currently a pediatric home model in your practice, or are we still working on getting that established? And if so, what sort of pediatric home model is it? How does it break down? How do the team members work together? Okay. And who are those team members? So when we're talking about this, what we want to think about is that in the pediatric home model, all of us are collecting data that's getting put into this electronic health record. And then we're looking at outcomes. And how do we go through this process of collecting the information? Who's collecting what information? What's getting put into the record? And then how are we using that information to look later at how they're doing? And then how do we integrate behavioral health in terms of providing care quality, cost management, and how does that factor into this system? But the team has already been collecting behavioral health data. You guys have been doing this for years and years, even before the behavioral health clinicians came on board. But how has that been obtained? Like, where is that information coming from? Who's picked it up? Who's obtaining that information? What sort of information? And when has it been collected? I'm pretty sure there's a scheduler in everyone's office that knows the families better than everybody else, right? They're the ones who deal with the people who cancel or don't come. Those pieces of information are integral to your practice, and figuring out where that information is coming in is really important. So when we were looking at the well-child visits in terms of what the recommendations were, what we wanted to accomplish, we went back to the Healthy Children Guidelines that came out of AAP, which is a list of recommendations for well-child visits, and they go through pediatric questionnaires, guidelines for physicians. I'm sure you guys have all seen this at some point. And there's a little tiny aspect on the bottom left side of these little pre-printed sheets that they give out each visit that looks at development, right? So you can see here, this is for a 6-month-old. Looking at communication skills, uses vowels, is beginning to recognize their own name, can vocalize, some very basic parameters in what you're looking for in terms of the whole entire visit, the other information that you're trying to cover. We realize these visits are really, in all practical purposes, given like 15, 20 minutes in your schedule. At a 6-year-old, you can see that there's not much more in terms of developmental parameters that we're looking at. There's like one factor for language. And how you assess for good language skills in a 6-year-old is a little open-ended and sometimes hard to determine in your 15, 30-minute visit. So are you actually getting the information that you really want if you're having these little teeny-weeny check boxes on the bottom of a worksheet that's giving you the sense of that, and how are you collecting this information? So I wanted to take one example of sleep. This is a basic regulatory capacity. Kids need this in order to be successful at any age. And it's one that develops over time. It's a very developmental aspect. Infants are sleeping in a very different pattern than two-year-olds, then that's very different than 6-year-olds, and adolescence is a whole nother mix. And so here's the checkbox for sleep. Normal limits, there's no parameters or giving you any additional information in terms of what to be thinking about or how to be thinking about that, except for the guidance that we want kids to sleep on their backs. But this is really the information that you're doing in your head, right? You're thinking through, like, are they getting enough sleep at this age range? How are they getting enough sleep? And so this is part of what we want you guys to start thinking about. You're already doing this in your head. The guidelines or the ways that you're collecting information are kind of within normal limits. But that's not always giving you this level of detail or the information that you need in order to be successful in providing recommendations and information back to the family. So there's 2 issues here. What information do you need to fill out your form or complete your data entry, especially when nurses fly into the visits before the docs come in or the NPs come in, kind of going through the little check boxes with families. Do you have any concerns about this? Does your kid wear a helmet? Those kinds of things. And then what information do you need to actually talk to the family to give them actual effective teaching and educational information that they can use to help raise their child in a healthy way? So successful practice management needs the former, which is that filling out the data and getting it all into the medical record. But successful behavioral management is going to require the latter. So to get a behavioral health clinician involved, they need more information than just a little checkbox that says it's normal. Okay, so what I wanted to go through and for you guys to think about is where do you see this behavioral health element integrated into your practice? So is it a frontline provider? Is everyone booked to see the behavioral health clinician? And the behavioral health clinician is collecting their own information from their perspective. Or is it a second line consultant where if an issue is raised, either with nursing or medical staff, that then the visit is kicked over to a behavioral health clinician? And to think about how the information may come in different depending on who it is that's collecting that data, okay? So within your own practice, does this have to do with the workspace? Right? So as a behavioral health clinician, I've sat in like back little closets where I've like magically appeared into a visit where everybody's being seen. Who's collecting it and then who's recording it? Is everybody charting separately? Is this all going into the same note in an integrated way where all the information is mixed together for the next clinician to pick it up during the next visit? And how do we actually think about it being a team? I know that that's the word that we use to kind of describe all of these people working in unison somewhere, but in terms of the team, do you actually have a shared knowledge base? Is everyone thinking of sleep being typical in the same way? Or are people thinking of it as being very different? And do we have the same meanings, the same vocabulary words and the same meanings with all those vocabulary words, especially when people are coming from very different training backgrounds? And oftentimes is the case when we're integrating behavioral health clinicians is that there's a existing and operating teamwork system that's already in place. And then you hire this outside person to come in and be dropped into the system. They work differently in all the different practices. Okay, so back to our approach, like why are we thinking about this? The well-child visit is very unique in the medical setting in that it's a framework of more towards public health, right? Preventative medicine, the focus is on prevention as opposed to intervention or an immediate intervention, which is really the bulk of the rest of medical care. This is the one opportunity, and I think it's a very unique, Jane and I both feel like it's a very unique opportunity for the medical profession where you're actually meeting with, hypothetically, very healthy children, and you're getting to provide education to kind of help keep them on that track, as opposed to intervening once there's a significant issue that's come to your attention. And our strategy is how do we revise this visit or think about this visit in a slightly different way to where we can use it to be more effective. We don't get much time focused on public health and prevention. And so if we're going to get 15, 30 minutes once a year, once every 2 years, how do we use that information to the best of our ability to ward off potential difficulties later on? Okay, so our caveat number one is that we're really focused on this younger age group, right, today. And so that brings us back to this kind of emphasis on behavioral foundations, okay? The very building blocks of how we develop basic skills that are going to support our behavioral health over time. And the rest of the caveats is that we're not going to tell you what to do. So there's no prescribed way of interacting with a 3-year-old or a 7-year-old. What we want to give you are some basic principles for you guys to take forth and think about as you're interacting with the well child visits and as you're thinking about how this behavioral health clinician gets integrated into your program. So not for specific ages, not for specific disorders. These are really principles, not recipes. And our goal is really to build the foundation for behavioral health, okay? Our target, based on the literature and based on what we hear back from medical teams, is resilience. That's what we want for kids to be able to do. We cannot prevent bad things from happening to children. What we want to be able to prevent is for them being dramatically affected by these negative experiences. So can we give them a solid foundation that protects them and provides this resilience to bounce back from hardship, regardless of their age over time? Okay, so resilience is the process of adapting well in the face of adversity, trauma, tragedy, or any kind of significant stress that kids may experience. And I'm sure you guys have a million experiences of seeing this in your clinical practices, but it can come from anywhere, whether it's school, it's a health issue, there's stressors that are on the family as opposed to the child specifically, but it can also be family changes, relationship issues at school. And what we want to be able to see is how kids can bounce back and how we can build that resilience early to protect them. So not just surviving, but recovering and then later thriving, okay? So resilience later on really depends on this development of relationships, which breaks down into responsive care from adults and care providers that are involved in their care and the establishment of solid regulation skills early on. The broader landscape of this, Jane, this is your slide for you to start, Jane.
Okay. All right, well.
A little odd to do it across waters.
Okay, well, my input here, I think it's important to say is that our experience, this is Jen's and my experience in talking to folks like yourselves over the previous webinars and workshops, is that you are all faced with exactly the same sorts of information that we are. And that the question is, how do we match it to this larger demand on us to keep producing more and more paperwork and deal with these electronic records, while at the same time doing the clinical work that is getting harder and harder to do? We see one of the reasons why behavioral health has been brought into the pediatric care team is because we are struggling with this issue of managing data on the one side, but providing clinical care on the other. And so this is the tension that we are involved. Now, when we look at the broader landscape and we sort of say, why do you want to get involved in all of this material? Basically, that was the answer to that was because we now know from a lot of research that has come from infants and more recently older children, that regulation is a critical feature of the child's development and is absolutely foundational to resilience, which is critical. When we look at this broader landscape, we also want to look at the what question. Is, okay, so what are we going to do here? So the parent-pediatric team relationship is going to be critical here. The initial proposal for a toolkit we're also going to talk about, which is the how question. All right, next slide. Now, first of all, let's just think about some points to ponder, as I like to call them. Next one, Jen, please. The basic principle that we've been learning over the last 20 years has been very clearly defined. What you do early is very, very important to what happens later. Next slide. So we are seeing multiple papers of this type. Okay, hang on a second, Jen. Let me just highlight the fact that we're looking at early variables and we're tracking to 30. Next slide, Jen. We're slacking to 32. This is maternal sensitivity. Next slide. And the paper that has really created an enormous amount of interest and focus is this one from Terry Moffat and her team, demonstrating very elegantly that features like self-control, early self-control, i.e. regulation, predicts health, wealth, and public safety in adulthood. You've probably all heard about the whole literature now on the fetal origins of adult disease. This is yet another flavor of that. This is the behavioral health end of things, okay? So the next point to ponder is, if Jen gives it to me, the other issue is that it's not a straight line from infancy to adulthood. Basically, the core central element of development, as I'm sure many of you are fully aware, depends on experiences. The system needs to interact with the environment, and anything that compromises that is a threat to development. It's very clear that a child's development, indeed adult development, is also sensitive to different experiences at different times. So everything doesn't come online in a steady linear fashion. It's nonlinear and it requires successive reorganization. One of the features that's always struck me very, very importantly is the whole notion of puberty. We're very easily provoked into talking about adolescence and how difficult they are. But if you think about the biological reorganization of the hormonal system, the physical system in general that comes about with puberty, you stop and wonder that if any adolescent could reasonably get up in the morning and put one foot in front of the other in a coherent fashion, because the whole system is under reorganization as the secondary sexual characteristics and reproductive capacity starts to be built in to the young organism. You've probably all seen this, this type of image. We would certainly bring your attention to the available information in the Center on the Developing Child at Harvard. The team here has done an excellent job of putting together a lot of educational materials that a lot of parents can handle. It's a huge resource, and it provides links to other important resources. But basically, what we're seeing in these graphs is how much information, how much development is happening, how early. So one of the reasons why Jen and I are very focused on the well child visit is that it's the pediatric team who do this. You're the guys and girls, you're the folks who actually are seeing the organism, the small infant and its mom or dad, in a period where massive amounts of brain development are going on. You are so important, it's not true. And like many other pediatric specialties, it seems to be like people who deal with young children are doing it for love. Why do we have to be paid? And we are routinely less well paid than other teams. This is also true, by the way, in education. But we cannot underestimate the potential role of a good pediatric care team to the later development of a child. Okay, next slide, Jen. So here's a very famous, it's now got to be a very famous slide. Or image. It came out of work done by Hart and Risley in the late 80s, early 1990s. And basically it demonstrates very clearly that by the age of 36 months, there is a significant difference in the amount of vocabulary available to low SES versus high SES families. Okay? And people always wonder about this. Go ahead, you can show this, Jen. And I, at one point, sort of looked at this and said, well, how about all these, this huge difference? Where is it coming from? So I actually calculated. So if you can probably look at this slide and say, oh, I know what Jane's doing here. 3 years times 365 days times 24 hours times 60 minutes times 140 utterances or words. So in the first 3 years of life, a young child has the opportunity to be exposed to 220 million utterances. Okay, next slide, please, Jen. Let's divide it by 2 because, of course, we have to sleep, but it's still a very big number, all right? So you have more than 100 million opportunities to interact with words in the first 3 years of life. When I computed this, I was very struck by the size of that. And in fact, if you look at the Hart and Risley data, you will find that there are very large differences between the low and high SESs with respect to the types of utterances they coded. So for example, they were able to demonstrate that in the high SES population, as many as 500,000 words were encouragements, right? With only about 200,000 being discouragements. When they looked at the lower SES population, they found that the discouragements were at the 400,000 or whatever it was, and the encouragements were only about 100,000. All right? Now let me make it very clear just before you stop and say, wait a minute, these numbers are ridiculous. An utterance or a word would be, yes, cool, good girl, wow, right? Those would all be encouragements. Whereas, no, hello would be discouragements, okay? So the actual quote unquote word should possibly be better said as an utterance, any communicative interaction with the child. And notice that you do this even with infants, all right? Infants learn from very early on because you converse with them. All right, next slide. There is, however, something quite interesting in this slide, or this graph, and that is what's happening early on before the 2-year period. So we still had a look at some of the data about what you could say here. Next slide, please, Jen. Okay, so we looked at what happens at 12 months and what happens at 24 months. The child is learning language in this period, so something must be going on. Okay, Jen. So what you can find from the literature is if at 1 year of age, a parent is talking with a child and saying, that is that is. When you look later at 8 years of age and you actually use something in academics, that's math, to measure your outcome, you find that the that is behaviors at 1 year are associated with good outcomes at 8 years. Next slide, please. This is a that is, okay? I'm sure many of you will look at this and say, oh yeah, that little finger's come out, the child wants words and he's talking. The other thing you might want to point out about this slide is, and I always like to ask people, is who's in charge here? And most people say, Luke. Luke's the baby, okay? You can see that Luke's dad is desperately trying to work out what it is he's supposed to label. Is it the car, the bird, the thing in the tree? And he'll keep trying until Luke seems to be satisfied. Next slide. What is interesting, however, is if you look at the use of the phrase that is at 2 years of age, that is not associated with the good outcome in the math at 8. Okay, what is associated? What is associated with good outcome then is not that is, but what is. In other words, the responsibility for finding the word has been transferred from the adult to the child. And this transfer to the child, so the child has responsibility for engaging in communication and working out what's needed, is a critical part of the developmental sequence. I'm sure many of you have watched parents telling kids things endlessly. And you sit there and say, Mrs. Smith, will you let the bloody kid answer the question himself? I find that frequently when you're dealing with school-age kids who are perfectly capable of answering questions about their own history, but are never allowed to. Okay, just so you know, the work that I've just described was actually from Susan Landry's lab, and it was deliberately looking at visual-spatial skills, executive skills, and parenting factors in predicting mathematical skills. Okay. Here is another example from the developmental language literature. Well, actually, it's not the language literature only. Here is an image, and one mother said, look, that's a car. See the car? You like it? It's got nice wheels. The other mother said, here, it goes vroom, vroom. I give it to you. Now give this to me. Yes, thank you. One mom is American. The other mom is Japanese. The question is, which one is which? Now, we are obviously at a disadvantage. I can't see all your faces going, oh, it's obvious or whatever. So I'm pretty sure I have to say, but it is indeed the mom, the American mom, who's likely to use language in the red sense, so to speak. Whereas the Japanese mom is more likely to use language in the blue sense, right? And what is seen as the critical difference here is that the mom, the American mom, tends to focus on the object and its features. The Japanese mom focuses on the action of the car and the engagement with the car in the relationship between her and the child. You all probably are familiar with the literature on cultural differences in how people relate the individual to the community and how you have to socialize your young children into your cultural group in that sense. And this is considered, this is an example of the sort of thing you might see. Remember that the two styles of language that the two cultural groups are using is being reinforced constantly at the 100 million, opportunities to interact in the first 3 years type of model. Okay, next slide. So these issues of early childhood and what's happening before you get to school are critical, and Clancy Bear and Sibel Raver are major players. And what we have really recognized is that self-regulation is absolutely critical to school performance early on. And you've all seen this because the teachers tell you they want you to be aware of this and do it. Not just the physical parameters, but the ability to do basic self-care, use language, be engaged and interested, pay attention, share and don't intrude, manage emotions to some degree, and recognize that other children are there and have feelings. All of these are much more, go ahead, Jen, it's fine. All of these are much more related to whether or not the child has been in coherent, organized, consistent, and contingent relationships in those early years, okay? The regulation is built on that. Sorry if I just did something weird there. It was because a mosquito flew by my nose. I am in the tropics, and I'm forgetting I'm on camera. So this notion of relationships has become more and more to the forefront of our understanding of how brain development functions. We as neuropsychologists cannot avoid it because it's the fundamental behavioral infrastructure for learning all the way along, okay? Next slide. So basically, the reason why we need to think in terms of regulation for children is that the skills needed are critical for independence, for exploration, and problem solving. And your responsive care that's in relationships in your early life actually predicts how well you will do in adulthood. And if it predicts how well individuals will do in adulthood, then it will also predict how well societies will function, so the issue of the early child development plays out in societal structures and policy down the line. Next slide. As we work, as you imagine, we are constantly in interface with the schools. And one of the big problems in education these days, there are so many, is this failure to recognize the importance of play in how children learn to think. And one of the things we do is to de-emphasize skills acquisition, certainly in the early grades, in favor of engagement in learning. The joy of actually mastering something is the critical variable, especially early. So we are focused on relationships, exploration through play, self-regulation, and then also the role of language development and use in this larger picture. Next slide.
Okay.
I
So
think,
go ahead.
I think you'll all agree with this, and so I will hand over to Jen to carry on.
Okay, great. So we're all in agreement that this is hypothetically what we should be focusing on in early childhood. I'm just going to assume we're actually all in agreement. It's not even hypothetical. Okay, so when we go back and we looked at those preventative health guidelines that we had talked about earlier, the AAP Bright Futures guidelines, you can see under developmental screening, this is what Jane calls a dirty great hole, this big gigantic spot where there's like no little dots at all, is the developmental screening section. Oops, it's kind of important. We felt like it could be filled in a bit, maybe. But how do we actually go about doing this when you can see all of the other things you're also supposed to be doing during those visits? So in the well child visit, we have this opportunity to actually see children while they're healthy as opposed to ill. And we started thinking about how this approach could actually be considered. How do we consider in a brief amount of time structuring the way that we're interacting with families? And by thinking about it from a strategic design approach, we have to consider what the actual problem is that we're trying to solve, right? So the goal is to promote resilience, the ability to bounce back from hardship. And we've said that that is really dependent upon these relationships, responsive care, and regulation. But in order to evaluate the relationships, responsive care, and regulation in a visit, you've got to actually see them. And this is where my own experience as a parent raises questions about whether or not my pediatrician actually got to see any of this. So promoting the relationships, responsive care, you've also got to be heard by the people who are delivering them. And this is something I run into frequently as a clinician, that families often don't hear what I'm saying. Or I'll have families in my office that are like, no, her neurologist 8 years ago said only 60% of her brain was working, and I want the other 40% to work. And it's like, there's no clinician on the planet that like can actually measure that. I'm pretty sure they were like trying to be more concrete in how they were explaining something, but it is like fixed in this mother's mind. And that is her ultimate goal from here on out to get that other half to work. So like how we're delivering the information and how it's being perceived are oftentimes discrepant. So there's barriers to doing what we actually need to do during these visits. Some of the barriers actually focus on the experience of both the child and the parent in these visits. So this is what we want our children to be like in these visits, right? Both our patients when we're interacting with them, and as a parent, what you actually are hoping your child is going to be like. But like the doctor gets to see like your child's like this happy little youngster who like engages in reciprocal play, like makes eye contact and is all cuddly. And this is what my children look like during our well child visits. The screaming, yelling, crying variety, because they knew what was coming. Which is a bit horrifying, especially as a psychologist, when you're standing there, you're like, no, my child is really much better regulated than this. But the other aspect of it focuses on the workflow. Like, how do you actually do a visit when the child won't come near you or is screaming at you, right? We have a lot of tricks for that, none of which are super wonderful things that we feel good about. Okay. So how do we actually support the child in a low-tech way, because that's how infants and toddlers work? How do we provide more support for the parents so that they can engage, they can hear what we're saying, they can be open and receptive to giving us information that we need? And then how do we support the pediatric care team to get these visits done in an efficient way where they're collecting the information that they actually need to do? So what we came up with, these were our ideals, right? So a bunch of psychologists sitting around. The DocPal idea came up with like using likely a soft toy, which I know is horrifically contaminated within 32 seconds, but something that's like soft, cuddly, warm, squishy that the child could pick up as they walk in the door. You give them a little bit of power. They get to make a choice in the interaction. They get to introduce themselves to the people at the front desk. They get to pick out their item that's going to take them with them the rest of the visit as something that gives them a little bit more power and authority in this thing where we're about to do some things that are not so pleasant to the child during their visit. We also looked into smartphone applications where we can link it to the data for the care team. We're sharing information back and forth. So the parents, I always filled out these like clipboards, like an archaic 1980s check sheet of like whether or not my child is whatever. And then I don't know if anyone ever actually looked at it, or like if it just got filed away somewhere, or someone took a photo of it and got scanned in or something along those lines. But like that information is collated somehow. I'm not sure how it's being used, but I never got any feedback on that form or any of these forms. They'd be like, great, you did great. Like we successfully completed the visit. Thanks for coming. And what I really wanted when I left was more than like a mimeograph sheet or a photograph sheet of a list of recommendations that are generic for all 2-year-olds or for all 1-year-olds. While that information is helpful, that my child should wear a helmet, that they should be in a backward-facing car seat, and it is important information, I also want information that's more specific to my kid, if that's possible. That gets me more engaged and it gives me more power to work towards doing the things that my pediatrician wants them to do. And so that kind of naturally led us to this smart form. Like, is there a way to like digitally interface between the families and the physicians to provide information back and forth, right? So this is like our pipe dream. I realize that, like, we're working towards figuring out how to do this with a hard toy or something along those lines. So this was like our little fantasy, right? The other thing I always was curious about is why in the doctor's office, they never seem to have any of those doctor visit books. Like we have like 50 of them at home because I'm a psychologist. So like we start a week in advance and we read the Berenstain Bears go to the doctor. And then the next day we read, little so-and-so goes to the doctor so that they're prepped for their visit. But when you're sitting in the doctor's office, there's no prep for the visit. Like there's no little thing there's no movie about somebody going to the doctor that's playing on the TV. There's no little book that the kids can read that like knows what's coming next, even though as they get older, they actually know what's coming next. And without any of that support, prep, getting ready for the visit, having an awareness of what's going to happen, how do you actually assess the child's baseline status? You're looking at them outside of a routine in a different setting, and you're trying to get a sense of what they look like in normal everyday life. So what happens as the kid actually enters the door, right? People start talking at them. They usually ignore the child and just talk to the adults in the room. Whereas like when the kid goes to preschool, everybody talks to the kid. So some of these things are just different. And what the child is thinking, they're super anxious because they're waiting for this. Like she's a little bit older than the age group we're talking about today, but my 2-year-old was fully aware someone was going to stab them multiple times before they left, which is why in the parking lot, he was already yelling at me and that he didn't want to go in the office. So if this is what the kid is thinking the whole time, we're not going to have a super high level of cooperation, and they're going to be super anxious, which how many of you guys are parents? What happens when your child is anxious? you're super calm and collected, right? No, of course not. Right? So like what's going on with the parent at this point? In our field, meaning in behavioral health or in psychology, the first principle in delivering education and feedback is like, can the person or the parent actually hear what you're saying? How do you meet them where they are? And if they're anxious and their kid is anxious and everybody's waiting for something to happen that they anticipate might happen, but they're not really sure, like, how is this engagement going well? So this is really central to behavioral health management in terms of getting that intervention, the engagement and the interaction to go in a different way where you're actually able to see the child. So parents are really bombarded with tons of parenting information, which I'm sure you guys are. It's even worse for us, right? Because we're reading all the research as well and are fully aware of all the reasons we should not yell at our child as we're yelling at our child. It's great. Just nod along like you guys also yell at your children, please. Okay, thank you. All right. Whew, okay. But so this is what's coming at them, right? There's like oftentimes their parents, a doctor, that's their unhappy mother up there on the left side. The medical care, different magazines and things like that, all telling them what to do. And the kids are kind of trapped underneath the parents in the middle of it. I love this video. And I'm not going to play it. You guys can go Google it this afternoon if you really want to. It takes a minute to get through it. And we're not recommending Nestle, who's the one who created this. But as you can see in the little snapshot of the video, it's like this little mommy war video about like the breastfeeding mommies versus the bottle feeding mommies versus the stay-at-home dads and like the yoga mommies that are carrying their children as opposed to the mommies in the fancy strollers. And like they're all facing off. And then at the end of the video, like somebody lets go of a stroller and like this kid is like headed down towards a ravine and like everybody jumps in and like saves the child. It's like heartwarming and you want to buy Nestle products or whatever. But the basic point is that like all of these parents are trying their hardest to do their best. And the perspective, if you're thinking about it from a medical team, is that like all of those people may be in your office the same day. And how are we going to tailor the message? Because everybody is going to hear it in a slightly different way based on their experiences. So they're swamped with this. Most of it's prescriptive. We tell people what to do. We don't ask them why they're doing it. And we're giving them this information over and over again, oftentimes in a way that makes them feel slightly guilty about the choices that they've made. And sometimes that means parents come to the pediatric team apologizing. I hear this a lot in my practice when I work with infants and toddlers, that parents are somewhat defensive or they're already explaining a choice that they've made when like I haven't asked them to explain a choice that they've made. So one of the questions I ask, I start with babies at 6 months and I'll say, how is the baby sleeping? Very open-ended, very generic question. I'm not asking whether or not the child is sleeping through the night, which is almost universally the answer that I get back, like, or the baby's still sleeping with me and they look horrified, ready for me to scream at them. But if they're already that defensive when I've asked an open-ended question, like, how's your baby sleeping? It makes me wonder what other information I'm not getting, right? So if they're hedging their bets with like the one piece that they're scared about, like, is there another secret thing that would be much more scary to me that I'm not aware of? So I'll have parents apologize for their bedtime. Like, really, the 6-month-old is not going to work. It really doesn't matter what time they go down to bed at night, as long as there's a general routine. Like, but the co-sleeping, I think parents get very concerned about actually saying this out loud in front of a clinician and what we might do to them. Co-sleeping can be fine. It is fine throughout most of the world. We have a lot of bedding issues in America with like big fluffy pillows and a lot of bedding, which makes our co-sleeping much more dangerous, but we don't usually explain that to parents. We just say like, no, that's terrible. You should buy a $300 contraption to put next to your bed that has an open side where the baby can fall out and, you know, that's safer. And so like for some parents, like understanding how the different dynamics and what they're supposed to do and why is not clear, and they can make better choices if we could deliver more information more effectively. And there's a lovely little site there if you'd like to know more about safe co-sleeping, because I'm slightly worried now that you guys are all looking at me like, oh, duh, that's not a great idea. Okay. All right. So can the parents actually hear? If they come in apologetic, defensive, they're all too likely to present information in the best way, right, to you. And that's not going to get you the accurate information that you need. So oftentimes with the sleeping question, I have to reframe it and say, I'm hoping to find out that your infant is sleeping 14 to 16 hours a day. They don't really care in what increments they do. You care that your baby's not sleeping through the night. I don't care, and the baby doesn't care. It's like, let's go back to like, you don't need to apologize that your 6-month-old is not on a perfect sleep schedule, right? Because you read the back of the Ferber book, not the whole book. Okay. But this also has a lot of implications for our practice in terms of the information that we're getting in and how much knowledge we have. So if the first person that's interacting with the pediatric care team sets the parent up to apologize, and this might be someone that hands them a checklist that goes through all the things that their baby's not yet doing, right? I often get that from parents too, like, my kid can't do any of the stuff you're going to ask them about today. Then the parent's unlikely to tell the next person. So this isn't just your, as a provider, your engagement with the family and the child. This is the whole system's engagement with the child, right? When the kid is running around the check-in area and like the woman can't check the parents in because the kid, like, there's already a sense of like, you're failing as a parent because your child is acting like a lunatic in the check-in area. Whereas the kid is thinking like, they're going to stab me with a needle. You know, it's like, if we set up the dynamic in a different way, how do we more effectively help these families come into the visit, feel comfortable, be able to share the information that we need to know as clinicians, and collect this information that we need from them more efficiently. All right, so this is where I hand it back over to Jane.
Okay, so one of the things we found is that in all of these recommendations or suggestions, we are probably asking you who have been primarily trained and influenced in the primary role of medicine, which has traditionally been to fix problems, and to shift into the more of the developmental mindset, which is promoting ongoing development. Okay, so there's a mindset shift here that I think the really good pediatric teams get. And if the team as a whole gets it, so the parents get it and everybody's happier. I think the first question in helping parents to get it is, what is not enough? Okay, so you can't just tell people what the answer is. You have to also give them a sense of why that is the answer. All right. And Jen said something earlier about you knowing a lot of information about sleep and sleep needs without necessarily bringing that knowledge to bear unless it's triggered by a question or a feature of the interaction. Okay. So one of the issues is all of us should be bringing our knowledge bases of development and sleep patterns and stuff like that to the forefront of our thinking when we are working with parents, and share a lot more information. I think the sleep one could very usefully be put, as Jen said, in a brochure type format. You know, this is what we expect in sleep in kids. It's not necessary that they do it all at once. It might bug you if they don't, but it won't bug them. I mean, Jen's points are, I think, quite useful in that area. But one of the questions here is talking with, not talking at. And we have a lot of work to do to make that shift, because one of the features of being socialized as professionals is we are socialized to take responsibility for other people's experience as well. And sometimes it's hard to give on that. Now, if we're going to realistically talk with parents, this is critical. The notion of shared meanings is critical. It's not shared meanings just across the team, which is also important, but it also is, we've got to make sure that what we are talking about makes sense to the families, all right? Now, this is at the basic level of another human being and another mom or dad before you get to the issue of how does a person from a totally different culture interpret specific medical words, okay? So basically, if you want to promote shared meanings, you need to explain why you want the child or the parent to do something and not tell them that you want them to do it. That's the first basic principle. Okay, so here are two examples of what we were thinking about narrative that you could come up with families. This one focuses, first of all, on the relationships issue, okay? So the first question would be, do you have conversations with your baby? And you can often get a blank look, like it's a baby, it can't talk. So what do? Well, you say, well, you know, Very small babies actually sort of talk with their eyes. Look, he's talking to you right now. Can you see? Okay, what are you doing? Okay. And so basically, I like to personally use, this is one of my favorite pictures in all time. This is a wonderful example of joint attention, shared interaction in a child who is, notice what other things are there. I use this slide to highlight the importance of communication and communicative interaction for language development. All right, because the child is interacting with mom very nicely. But the other issues to highlight for us as developmental practitioners is the child is safe. The child's brain is not panicking about survival. The child is being fed. The child is experiencing not just physical nurturance, but also emotional nurturance, okay? And the child is being responded to. So all of the basic adaptive needs for survival are in place for a child of this age, right? And when we start looking at children under stress, of course, one of the things we've learned to think about recently is the importance of some of our negative behaviors as basic survival adaptations, right? Next slide. So basically, as babies get older, they talk with their face. Their eyebrows go up or come down. Their cheeks crinkle. Their mouths open. Their lips pucker. I would bring you to the attention, if you haven't looked at it already, there's a very nice new video on the Developing Child website for Harvard that demonstrates on a video the interactions of the baby talking to the adult in the framework that the Harvard team call now, or is called in the literature, the serve and return model. And there are very nice demonstrations of how the baby is serving by a facial expression and the adult is to return with a remark or a facial expression of the same type. But the bottom line is a lot of parents don't really realize that this is important and it's part of communication. They do it, but they don't know what it's for. Okay, next slide. So you also have the arms and legs and the back movement and the moving towards or turning away. And very small children do this, and they are telling you loud and clear what it is they want. Next slide. So here's a classic example of a little person engaging with its mom. Clearly thinks that she's part of the interaction, and I guess he's trying to feed her, which is really rather nice of him. Next slide. Basically, you talk back with your face and your words. And I don't think that we do a good enough job of pointing out to the parent, oh, look, you're talking back to him. Look how he got back to you. Oh, and you can do this very quickly. This is not sitting in this is not sitting in your office and taking 5 minutes. Let us talk about conversation. That's not what you're going to do. You can just, as you're filling in your notes, say, isn't it nice how he's talking back to you and how you're talking back to him? Type, right? Next slide. So, do you have conversations with your baby? You're going to educate the family very quickly as you go along and take the conversation. But if you watch what's happening and you see no responsivity going back and forth between the adult and the child, no attempts at eye contact or other behaviors, those would be immediate triggers that you need to think about the developmental consequences of this, and therefore you need to think about behavioral development, and therefore you need to think about the behavioral health consult. Okay? You might, of course, want to, if, as Jen said earlier, we raised the issue that if your behavioral health if your behavioral health person is in fact a frontline provider, you can immediately see where you could, what part of the knowledge base that you need on this child, that you're going to put in the electronic record, could be collected by the behavioral health person, who could be actually watching interactions. Okay, next slide then, Jen. All right, so look at regulation. The question for this is, do you and your baby have a routine yet? Tell me about it. Do you routinely ask about routines is our question, because these are critical to how A, babies function, and B, families function, and you need to know. Let us just remind ourselves as scientists here that regulation is not exactly something esoteric. It's a core feature of the mammalian brain, and probably non-mammalian brains as well. And it's manifest very deeply in the brain, in oscillators, in circadian rhythms, in all of the homeostatic mechanisms that keep us functioning, from the basic physiological functions right through to cognition. Okay, so this is not something that's new, and it's certainly something that's embedded. Okay, next slide, Jen. Is this the one we always question?
I know, we tried it this morning and couldn't get it to work.
Okay, try it, see again.
All right, I have one on my phone.
All right, well, I have done over the years quite a few workshops with young parents in various guises. And this slide has been easily the most dramatic and interesting of all the ones I've done, that parents love. Oh, I can hear it now.
That's my phone.
The parents I have worked with have absolutely loved the idea of this basic rhythm of life, that the heart is pumping for the baby from the moment it's, actually from the moment the sperm and the egg get together, all right? And so it's a very potent image and sound to emphasize and ground this notion of rhythm and regulation, all right? One of the interesting things that is been just, I won't say it's been tested in the literature, but it's certainly there, is that if you ask moms which side they hold the baby, okay, many moms will put the baby on the, or you say, show me, mom will put the baby on the left arm, right? And so you say, well, why you put the baby on the left arm, right? And most moms will give you an explanation of some sort, like they need they're right-handed, so they need their right hand so they can say, hi, baby, how are you? If you ask left-handed moms to put their baby on their arm, most of them actually put them on their left arm. So you ask why, and they'll say things like, it's my left arm, you know, it's my better arm. But in fact, if you stop and think about how the organism works at a basic level, the reason why people often, or most often, put babies on the left side is that the baby soothes better on that side. So from the mother's point of view, it's just a basic learning, conditioned learning, right? Why does a baby soothe better when their head and ear is on the left? Well, it spent 9 months in a womb with this darn oscillator going ba-dum, 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 and regulating it perfectly well. This is soothing. This is how you hold yourself together. And when you put the baby's ear next to the heart on the left, ta-da! Judith Gardner did some work with premature babies, one of the New York teams, quite a while ago, and they had a little bear, a little teddy bear, in the preemie incubators. And the bears had little electronic heartbeats. And what they were able to demonstrate quite elegantly, actually, was if they changed the rhythm, the rate of heartbeat, or the rate of the little beat in the bear, the babies then trained themselves to the new beat very quickly. That basically the rhythm, the strong rhythm out there is very important to us. And of course, many people think that that's why dance is so critical to the development of human beings and human societies. But that's a huge other literature in another direction. But as far as we're concerned, the message is loud and clear. Regulation is heavily buried, if you will, or embedded in the system. So you need to take it to the real life situation, the lived experience. What rhythms are there in everyday life, and what can you, as the clinician, promote? The same sleeping place, the same sleep time, the same wake up time. Does this sound like, you know, recipes for adults with insomnia? The same eating times, the same toilet time, the same school time, the same home time. Some of these are imposed, like school time and home time, but some are often recommended as creating the rhythms and routines of life. By the way, one of the interesting things about this is one of the biggest challenges for individuals who are homeless is the difficulty in establishing rhythms to raise their children with, which is an interesting point, I think, in itself. Notice, however, that life for small children is full of these things. So next slide, Jen, you can go here. So basically, you could look at it this way. Rhythms lay down the tempo of life. Routines set up the beat. Rituals shape the storyline. We tell stories to children. And then rules guide the way when needed. All right? So you can actually think about some of these ways in which we can try and do this. Notice that you are actually helped quite a bit these days by the various programs that support children in the early years. So Jen and I got involved in this work way back by working with the Thrive in 5 program that was set up when Tom Menino was mayor of Boston. And this is Boston's early childhood program. And we got involved because we were asked to help create brochures that would help us help parents see what was needed. Unfortunately, what we found was this was endlessly focused on what you might do early to help your child to read. And it tended to be recognition of letters and things as opposed to learning to do rhythm, rhyme and engage in rhythmic behavior and stuff like this, which has been shown to be important. Next, Jen, please. So, do you and your baby have a routine yet? Tell me about it. Okay, so you get some information. Then you say, well, we want to get a rhythm going between you and your baby. How does your baby soothe himself? How do you soothe him? When, how much does he sleep? How does he get to sleep? Does he eat on the regular schedule? When do you play? Do you enjoy him? We find that this question is not asked enough of parents. The notion that they should be enjoying their kid needs to be put front and center. They are often enjoying their kid, but they need to know that that's a good thing and okay. Notice that in this education, we've gone after the regulation, the basic regulatory skills that are going to need to develop. So soothing, sleeping, eating, toileting, and playing perhaps less, but are all basic rhythms. And we call them, when we write in our reports, we talk about the basic regulatory system or whatever we do, but we use the word basic regulation to characterize sleeping and soothing and toileting, etc. Again, in the intervention, you would be watching for behaviors, you'd be watching for what lack of information on the part of the parents, you would be looking for those sorts of aspects of derailment of these basic rhythms that would trigger the behavioral health consultation. Again, if your behavioral health person is a frontline provider, then you would want to work closely with them about thinking through the development of the regulatory cycles and skills. Next one. Now, there are lots of information and there's huge literatures out there. I'm actually in the process of writing something called From Knowledge Base to Clinical Case, like how do we manage all this information when we've only got one person in front of us that we're trying to help. And one of the things that we're very concerned about is where the heck in anyone's practice is all of this going to fit? We are very much aware that you are under huge constraints of time, like everybody else, and that we are all obliged to use these electronic health records. Okay, the big mantra right now is outcomes, which is a challenging thing in itself. And so we did give some thought when we started thinking in the larger picture of this to how do we actually integrate new information into ongoing systems. Well, this is where we would argue to you, back to you, that a strategic design mindset is important. It isn't good enough to add stuff to what you're already doing. There isn't enough time, you're already pushed. And so you need, for your individual practices, and this is why Jen and I decided to do a larger sort of overview type of approach, is that we don't know each of your practices. And by the description, they have very different packages of personnel. But we assume that everybody has some sort of secretary, administrator, receptionist at the front who also needs to be included in the team. So we would recommend strongly that if you are going to, if what we have said to you makes sense, that you actually convene your team and make a deliberate attempt to rethink the game. Don't just add questions about development to the system and say, I hate Bernstein, I hate Quealy because they suggested this and it's ridiculous. But do what we did with saying, well, okay, back off and say, okay, given our team, given the personnel, given the availability on given days, how could we reshape this so that the whole system will allow us to see this missing bit of regulation, okay? Because as Jen said, I really do think, and that's my first reaction, it's a dirty great hole in the Bright Futures graphic, right? It tells you something. It tells you people don't know how to ask about it, don't know how to put it into some sort of form, all right? Next slide, Jen. So this is what we're talking about. You need to make a commitment as a team to shared meetings. And if you don't, you won't be a team, right? I think that's important. You need the behavioral health practitioner in the practice, which I think from what you were saying from the chat and other people's comments is pretty well everybody has somebody in this role, all right? The question, just hold on that a second, Jen, but two, the problem you're gonna have, maybe, is that we're asking you to ask your behavioral health practitioner to talk with you about promoting development, not just helping you manage a child who is anxious or who looks as though they have ADHD and needs a behavioral management plan, or who, in other words, we need the behavioral health person into the preventive mindset, as well as the I'll help you with the disorder mindset, all right? That's, I think, very important. Jen, I don't know whether you would agree, I'm sure you would, but that is critical. Not all behavioral health people are going to be in the same frame as we are, all right? Because they may have skills in cognitive behavioral therapies, things like this. So this is something that development is a pediatric issue, but you might need to get your behavioral health people to be pediatric in the same sense, okay? The other issue, I don't know whether your teams have ever addressed this, but it would be useful at some point if you decide to make a commitment to teams and shared meetings to actually look at what constitute different types of teams. Because I would argue that a really great pediatric home model would be transdisciplinary, not multidisciplinary, not interdisciplinary, but transdisciplinary. And that usually is taken to mean that in a way, everybody could do every job, i.e. the shared meanings are across the whole system so that people are all telling the same story. It's not that they're separate stories and then you talk about how the separate stories fit together or don't, as the case may be. So the third issue is we live in a technological world, and it's clear that there are technologies that can help. Many of you will have been asked to deal with EPIC. And if there's one four-letter word that recently has been the most resisted four-letter word we know, it's EPIC, right? However, it seems as though EPIC's getting a little better, and as practitioners, we often have no option but to use the technology that's brought to bear. So next slide, Jen, just talk a little bit about. So when we start talking about technology and how do you harness it to help, we're thinking about it's no good asking busy, overworked teams to do more of this technological stuff if you don't make it user-friendly. I actually think that the team should be pushing back harder on the technology types, on the IT people who are designing these things, about what's realistic and what makes flow sense for busy clinicians. The information should be accurate. I don't know whether you guys have been experiencing this, but there's a big problem now with the electronic medical records in that people are doing a lot of cutting and pasting from previous notes. And if there's an error in note 1, there'll be an error, equally bad error in note 10, right? And nobody's actually checked that it was left rather than right, or it was actually liver rather than kidney, or what have you. The other issue is if you're going to ask busy teams to get more information, it's got to be worth their while. In other words, it's got to be useful to the team, okay? And I don't always feel that the IT people, the design folk, get adequate information from the real teams on the ground. They get them from other physicians or other psychologists or whatever, but they're not necessarily the teams on the ground. So you might want to consider that your team may need the technology specialized or focused for your type of practice. Next slide. So there are a range of technology-based solutions out there. In fact, there are so many, it's hard, and your IT team will presumably choose it. So you want to think about how easy is it to enter the data that you're going to have to put in there, and how easily can you access the data you might need to help the parents, all right? And these are actually relinked questions that are quite, quote unquote, easy to technologize. Next slide, Jim. So now what you have available, I don't know whether it's available to you directly, but basically what's available now are these so-called smart windows, which basically embed the user interface into the workflow. And if it's not doing that properly, then it's not a good one, and you should argue back with the PPOC or whoever's asking you to do these things. There's a lot of stuff out there to call on and to use, so there's no excuse for being able to do this properly. By the way, if you sit there and say, well, it's all very well, Jane, saying this, but the bottom line is our IT guy says we can't do it. And you can say, because of Epic, you can say there's a whole pile of technology out there now that translates between any other technology and Epic. So this has been a focus of, the problem of bringing databases to bear. So it's not as though it's not doable. Next slide. The application in this would use data provided by the clinician combined with the EHR data. Now, it's then managed in the cloud, all right? And then you can deliver it through a smartphone app. Now, there are several very technologically savvy folks who've been developing really interesting smartphone apps. One of the obvious usages, now, the first thing to notice is irrespective of your practice, whether it's high SES or low SES, the smartphone is becoming ubiquitous. Everybody has one. There is no reason why you could not pick up Mrs. Smith into your practice and have your receptionist create a file called Mrs. Smith. And when Mrs. Smith has an appointment with your physician or nurse practitioner on Tuesday, on Monday morning, Mrs. Smith gets a message through her smartphone app saying, "Good morning, Mrs. Smith, your appointment's coming up." It's populated with all of the data about the child who is now a different age. Are there specific problems you want him to address? You could even say, you could have a checklist about sleeping, regulate, or whatever, language, whatever, if you wanted. So that, and then when the person comes in, it either goes up to the practice's website, or otherwise the smartphone could be handed to the receptionist to put into the system so that what's on that app is fully populated for today, for this child, for the physician or other clinician. That is plinkety-plonk stuff for smartphone apps, okay? And there are a lot of apps like that. You should not be collecting those data separately. It should be delivered to your screen if you're using a screen on your desk, okay? I see, Mrs. Smith, I see you have, right? Not, tell me about, I see you have, tell me more about it. You're already well into the discussion. All right, next slide, please, Jen. So basically, these sorts of things can also provide between visit education, if necessary. You can access Dr. Smith app. It populates immediately with the age reference data. The information is targeted to the developmental stage and issues as recorded by the care team. And then it also, if the parent uses it, gets feedback. Now, I worked a couple of years ago with the Wyoming's early childhood program. And as part of that, every day at 6 o'clock in the afternoon, I get a WhatsApp on my phone, or a message, I think it is, a text message. And it gives me one screen that says, talk to your child about the colors in the room. Or when you go here, count the numbers on the screen. And it gives you these little instructions at 6 o'clock every day about how you can engage your kid in language. I'm getting a little sick of it since I know what it is, and I haven't worked out how to make it stop yet because it's been running for like 3 years. But these sorts of app data you can tailor to your own team, structure, belief system, right? The big advantage of this, by the way, a big advantage, is that you can provide through your website and your smartphone, your technology, information which you believe in and know to be reasonably accurate. And I'm sure many of you have had the challenge of parents coming in to tell you that they went on the internet to look up this, and they are trying to do self-diagnosis on the internet from websites with very peculiar names, right? So anyone who is facing the technology era, as we all are, the landscape, who has specific evidence to provide might like some way of assuring themselves that the information being transferred to their patient population is in fact information they feel comfortable about. Next slide, Jen. So I think that we've ranged widely here, and we hope that we've given you some ideas about, as we call it, revisioning the well-child visit. Not making it longer and longer, but rethinking how all the parts could fit together, especially with the behavioral health person. And I think we haven't done the webinar in this form before, right, Jen? So I think at this point we have time. We would like feedback, or we would like comments, even if they're of the order of, what the hell do you think we're doing already? We're doing this anyway. We actually don't believe you. That's what's been said in the past. And then when we analyze what people are talking about, it's not quite the case. But we would be glad for individual online through the chat, or if you want to chat back verbally, I think we can do that, right, Jonah?
Right. So I just wanted to provide an example. One of the things that we talked about earlier was that anticipatory anxiety for some kids is pretty profound when they're waiting on their shots or immunizations every time. So one of the times that we delivered this talk, we talked with teams about how they might reorder those. There are some children who may want them at the very end of their visit, but there are some kids who would rather just get it over with, and then they can pull themselves back together and have the rest of the visit. And it seems like that's a conversation that's kind of left to the parent to advocate for. But if there was a way that within your medical record system, the kid was identified as an early shot taker versus a late shot taker, that may make for a dramatically different visit each time the child came in for their visits. And it becomes a part of that standard routine of like, I'll get the bad part over. My kids love the hearing and vision tests at age 5. They thought that was like the best thing ever because they got 5 minutes alone with a provider who is doing nice, kind things for them and had headphones. It was like super exciting as opposed to what normally came at the end of the visits. And so in that sense, like thinking about how within your practice or what things have you done already that kind of fit in with the ideas that we're talking about here, to either tailored for specific children, to think about how to support regulatory capacity or how to get better information out of families that's more accurate and more representative of what's going on.
Jen, I remember it might have been you or one of the other pediatric care teams who pointed out that sometimes for some children it would be good to tell the mom to not feed the baby, the infant, until just before they arrive at the appointment. The issue being that the child meets the challenge of the the appointment and what will happen there at a point when they are actively being nurtured and actually looking for the nutrition and the nurturance at the same time. I have to say, I hadn't thought about that, but of course the mom would be better regulated if she wasn't trying to handle a screaming infant. That's the other big issue. So
Jane, we can't see the chat. If you see things that come up on the chat, can you read them out loud?
So far, the chats have all been, well, I don't know. Oh, man, 3 new messages. Wait a minute. Now, everybody who's chatted has told us where they're from and, what their structure is. And just a comment, I think we range from, 11 MDs and 2 nurse practitioners to 3 MDs and 4. I mean, the pediatric care teams seem to be of very different shapes. And that was one of the reasons why we thought, why we're very keen that this is not prescriptive, but you need to rethink it to match your system. I mean, I don't know, maybe somebody could just get started by saying, if you have the group that has 11 physicians and 2 nurse practitioners, who is always in the practice? In other words, are the 11 MDs all there at the same time, or do they have days, whereas the nurse practitioners and the behavioral health people are there all the time? That's a different model than if you have 3 MDs and 4 nurse practitioners who are all full-time. You know what I mean? So you would need to match your team building to that. To me, it would be a bigger challenge if you had people who weren't there all the time to build the sense of shared meanings. But I don't know, well, people might feel very differently.
I think people have no feelings.
Hi. So the vast majority of practices that I'm aware of, we all have sort of different combinations of days and different combinations of providers that are there at different points. So it would be a pretty rare day that there would be one person that's there all day long during banker's hours. Our teams are largely day dependent, but always depend on the same core members. So the person that brings the patient in, the person that greets the patient, the person that works with the patient behaviorally, the person that works with the patient for complex care needs, as well as the person that provides the physical medical care. So our teams are consistent with roles, but they're not consistent with
Specific staff.
Which specific staff fills that role at that time.
So you would have to, all right, let's assume that one has a commitment to changing the system a little bit. In order to sort of build the team in a way we're talking about, you would probably need to have some sort of, I hate to say this, but retreat. You know what I mean? You'd probably have to commit some time to bring everybody together to talk about how the system is going to be modified. And then you would have your core team would be the ones who would be holding it together, as you say, in banker's hours, right? I mean, I don't really, it's a challenge because you'll find with a lot of people that people are very differently committed to the notion of developmentally framed thinking.
There's like random beeping going on. Something's all done.
You see, I'm reacting to your, I'm sorry, you didn't say what your name is, so I don't know what I can't use your name back, which would be polite. But if you have a team that has people who specialize in coordinated care and what have you, it's not as though those people are separate. We're talking here about development. If kids are have major developmental disorders and need coordinated care, then the need to discuss the developmental underpinnings of organized behavior is even more important, right? So this core notion that the primary goal of the well-child visit is to promote the development of healthy kids, which is what we believe it is, and not to, the primary goal is not to fix everything that is broken. That's not the well-child model, right? Then it doesn't matter if the child has a disorder that has derailed development. Our job is still to try and get optimal developmental progress given the constraints imposed by the disease or the disorder, right? So there is an issue here of what we're pushing for is a sort of notion of understanding development better, or integrating the notion of development more comfortably. I have to say, it was a shock to us when we looked at that Bright Futures and saw that, what I call the dirty great hole. It was like, hello, this is pediatric care. It's well child. Why are we not looking at development? Especially now that the literature is coming out thick and fast of the importance of these early features for later behavior, both social and medical. Okay, nobody cares. All right. Then tell Jonas Bromberg that we are not going to do this webinar again. We will.
I think Jonas has a comment now.
It's much more fun to actually interact.
It's hard to be electronically connected to people because you can't see them.
Yeah, I can't see. I can see a whole set of what look like Brookliners whose faces are less than. Let me have a look. You Brookliners, I can see you, right? I can't see the North Adams contingent. All I can see is PPOC Northampton and everybody else by name.
Ha ha ha.
Haha, so I don't see faces, right? Ah, Northampton, yeah, there you are. Okay.
So besides reorganizing the shot, why don't we make it more specific? Besides reorganizing what order we do things in, now I can't get this to work. Are there other concrete things that would be easily instituted that we could do that would allow for some adaptation? I totally broke it. Some adaptation to either support better regulation in visits or to better support kids' engagement with you. Do any of you guys have this issue, or all of the kids who come for well child visits are like smiling, happy creatures? Yes.
Hi, I wanted to add some comments.
Great.
So you're referring to the big hole in Bright Futures. I wanted to just put, we do the SWIC instrument at every visit in the first 3 years, where there are some questions about regulation and development, and it's not a big hole. There's a systematic framework that we're all following. And I guess what I'm wondering is are you saying that some cross-cutting developmental themes like promoting resilience by talking about regulation and sleep is a hole that you see missing, and something that needs to be sort of promoted over some of the other priorities?
I think, Jane, I can try this. So I think one of the things that we've noticed is that regulation is harder to assess with a checklist. So you can hand a parent a checklist and have them say, how many vocabulary words does your child have? Or how far can they walk before they fall down? Or basic kind of developmental rubrics that we use to kind of cheat and get those motor milestones or language milestones. Regulatory capacity is so much harder to measure with a checklist. So when you say, like, is your child well regulated? Like, what a parent understands about that or has a sense of what you're talking about, and whether or not they're sharing the same kinds of meanings with you or their understanding with you is just a little bit more challenging because it's hard to gauge. So I'll have families say, oh, well, my 2-year-old, she refuses to do what I'm asking her to do. And she sometimes throws things. And I'm like, well, aren't you lucky that your child actually is like so engaged with her environment that she has thoughts of her own, is capable of organizing behaviors and actions, is capable of like mounting a resistance to you. Like a lot of the patients I meet with can't do that. And then reframing, like this is appropriate or this isn't appropriate or this is how we help manage these types of behaviors. But I think what gets hard is when you ask a general question, like, does your child have difficulty with regulation? That doesn't have the same meaning for other people like it does. Does your child learn 20 words? So it is helpful for us to have a sense of what you guys are doing. So we'll read through the SWIC and see what's on there. But I think that was one of our struggles, is finding anything on the developmental, on that website that kind of went through some of those features and how you measured them in some kind of concrete way. And then if in the visit, children are dysregulated by the way the visit is set up or the demands of what needs to occur, multiple people coming in and out of the room, multiple people talking to people, things that are somewhat painful, being naked in a strange place, that your ability to observe regulatory capacity can also be problematic, if that makes sense.
Yeah, I think that's the question I would come back with you to your comment, if I can, is when you fill out these sheets, what are the behavioral observations you are making? And I think one of the questions we would have, if you're going to do it by checklist, which, you know, is how you put them into the darn EHR, our issue is the one we started out, you know, with the little graphic of the eyes, is what are you actually seeing as a clinician in the setting? So I know that one of the issues is exactly what we said, is that the child may be perfectly well regulated at home, but they don't like the doctor's office, so you see a screamer. How do you fill out a regulation checklist, assuming it's a good one? How do you do that if you don't either create a situation where you can see it or ask very specifically, how do you do this at home? I mean, one of the questions we would have, for example, say you have a child who's lost it in your office. I mean, I would be asking, how do you usually manage him when he gets like this, right? I mean, that would be rather a different mindset, because it would give you information on the child, on the mother's or father's, if it's a father. It would give you information on how the parent tackles this, or, you know, is he like this all the time, right? What do you do? All right, where does that fit in the checklist? Do we have checklists? You know the checklist better than me. Do we have checklists that say, at the same time says, child is, you know, distressed at level 6, mother does X and Y. Do you know what I mean? You know, there's a part of me says, why do we have to have a checklist? Because the good pediatric specialists with a lot of experience will just directly go and help the parent and talk about what to do. And you know what I mean? But the question is, for us, is this embedded in your practice? Or, you know, I wrote somewhere one time way back that development isn't like something, it's not an extra moderated variable. Development is the core. Right? It's not a variable. It's not like salt and pepper on a stew. Development's the stew itself, right? And that is something that's not part of our thinking in American culture. Do I sound very English? I've been in Trinidad for 3 weeks, so I'm making statements about American culture like I don't know it or something. Okay.
I guess my 2 cents is that, I mean, as pediatricians, I feel like I enjoy that part of it a lot better now that I've been doing it for 20 years than when I first started, because I feel like it is impossible to, I think, to sort of tackle some of these regulatory issues at every visit. But I feel like as I get to know the family and as I get to know the child, I know some days when this child is not regulated well, but there's something going on. There is a loss in the family, or there's different things that might affect that one visit. So I don't necessarily judge is not the right word, but I don't necessarily judge that this is how a child normally regulates when I've known him for 12 months or 2 years or what have you. And so I feel like these are really important topics, and I feel like it's been very helpful to kind of get a sense of how else to frame questions and think of the parents' reactions in that setting when they are dysregulated or having trouble. But the beauty of trying to have a main provider that person always sees is that we get to know them and that we get to get a sense, is this how they normally interact or not? And that just comes naturally when you've been seeing them throughout the 12 months, and then suddenly at 15 months they act like you're a demon, you know, and they never want to see you.
Right.
And I always just tell them, wow, I think something was wrong if they didn't cry right now, or this is completely normal and this is totally fine. And they're going to love me again at 2 or, whatever in a certain, in a joking way. And then sure enough, by the time they're 2, they're much happier and the family's much more relaxed. But we try to just sort of help them along at those ages. And so you talk more about, how do they do at home? And so I think it can't be done at every visit because it's not always possible, but we also know there's certain visits where that's not going to necessarily be the time to discuss it because the family is going through something else or you are privy to that information that there's something else that's happening. That's not how perhaps a child normally relates. So anyway, I think it's a continuum, I guess, is how I would look at it and why.
Hang on to the microphone. So one of the things that we've seen change over time, and I think the more times we've given this talk, the more salient that's been, is in the smaller practices where if you're working with a family and there's 4 docs in the office and you follow the Smith family and the 4 Smith children, you do know their parenting styles. You know what Timmy's like when Timmy comes for Michael's visits, et cetera. And you can build that sense of understanding. When you're coming out of a practice with 13 or 15 practitioners, where sometimes the people come in the morning or sometimes they come in the afternoon and the sick visits are with, I had an experience with one of my kids where we wound up finally admitted, but we saw 8 different doctors in our practice in the span of 1 week. And every time we went in, every single provider had a different idea about what was going on, and the information wasn't shared effectively because there wasn't a way to capture it in the system. And I think that's part of what we're trying to think about is in a larger practice, if you do 1 well child visit a year for a child, you don't have that same understanding of what Timmy's normally like or not normally like because your colleague saw Timmy the last visit. And that piece makes it really hard. So is there a way that we can capture this data point to be able to use it again in the future? I think we'd all agree that the model that you're talking about is ideal.
Yeah.
I
would like to make a comment back there and say, I'm glad you're having fun now.
I know, thank goodness.
But what you just said to us is something that's really important. And it isn't just a throwaway line to the parents. It's direct psychoeducation that everybody should be doing when it's appropriate, which is just as a throwaway line you said to the parent, well, this is what I'd expect to see when he's only 18 months. We know about this. It's called separation anxiety. There's a literature on it. You know what I mean? Parents are very helped by being reassured that even if the behavior is, killing them, it's actually expectable to the person who knows it, right? So just by that one phrase that you might have just walked past rather quickly, the parent, you've done a major job of psychoeducation. Now, hang on a second. I've got a message here on the chat from, I think you're called Lisa, right, Lisa? Because it says Scott, but then Lisa comes up.
Yes, it's Lisa.
Lisa says she does feel like identifying children with regulation difficulties is not the hard part. So she feels that she sees them and can discriminate them from, I presume, Lisa, you're saying you can say to yourself, this is not just the context issue of the setting. But she says, then how do you help the parents once we recognize there is an issue?
So I will say that I definitely feel that I'm in a smaller group. We have 5 MDs and we know our families very, very well. I do feel like with the screening development and getting those relationships developed, we can pick those kids up. The hardest thing that I've had moving forward is some parents, well, most of the parents want to be super proactive. They're looking for help. So, we'll identify these issues and then we'll say, okay, early intervention, we'll try to get them parent support groups. And then especially as we leave toddler and we go into that preschool age group, I'm having a hard time giving them resources or saying, here, you can do this. And even when I've called for help, like we have one kid, significant regulation problems. He's 4. We saw it coming. I feel like if I could rewind, I wish I knew what I could have done differently, but you kind of know it's going to play out. And then even when I've talked to, psychiatry, they'll say, well, we wouldn't do anything right now anyway. Things are still evolving. And so we could see them, but it's not really going to change anything. So you have to send them to development. Then there's a a 10-month wait to get into development. Like, I'm just so frustrated with this whole part of it. And I would love to see our practice really kind of develop those resources and really find like a track we can get these families and kids on so that we can actually make a difference. Because I do think this is the time to make the difference. I think this talk was super important, but I don't know how to implement, you know.
I'll tell you, you made a couple comments that are great, and I'll tell you what we've done in other places and we know works, all right? It depends. First of all, do you have a behavioral health person in your practice?
We do, and she's been there now for about a year.
All right, I'm not going to ask about whether you think it's good, bad, or indifferent. That's not what I'm after. One of the things here is that you've got two issues. You've got the kids who are not as regulated as they should be, but probably are within some sort of normal range. And the kid that you know has got a major problem with regulation, and even the best parenting is going to be challenged, right? There are two groups here.
Yes.
If you are really interested in doing something in your practice, then I would strongly recommend putting together a parenting group.
Okay.
I mean, we use common sense parenting in one of the sessions. I know some people who use Love and Logic. There's the Triple P model that I can't remember his name, developed in New Zealand and Australia, which is very widely known. I would set up a 5 or 6 parenting group. I would ask for your behavioral person to do it. Bring the parents together to teach them what they should be doing about better providing a regulatory environment, because that's what we find parents don't know how to do. They need help with appropriate discipline. They need help with imposing limits. They need help in doing all this non-punitively, et cetera, but strongly recommend the parenting group. Parents really appreciate it, and they don't feel told to by the physicians or the clinicians when they're asked to, they're given new ideas and help to problem solve how to do it. So I've actually become quite a convert to positive parenting, common sense parenting. The common sense parenting one came out of the Boys Town in Ohio or wherever, I don't know, but there's some really good stuff, and your behavioral health person could be the facilitator if they were interested. And your team could be as well.
And these are like programs that already have like a structure essentially to providing the program.
They're often like, 10 module units that go for a period of time.
Okay.
We've found parents are very receptive. I mean, I've been, as I say, it wasn't like I didn't think they would work to start with, but boy, a lot of, the bottom line is nobody gets parenting 101. And a lot of parents didn't have especially good models of parenting in their own parents. So providing some support is helpful, and having it in a group form is critical. So I would recommend that strongly. Absolutely.
Jane, what were the names of those? You mentioned PPP and a couple of others.
It's called Triple P.
Okay.
If you put Triple P into Google, it'll pull that out. Common Sense Parenting is the one that comes out of Boys Town. There's one called Conscious Discipline, and there's one called Love and Logic.
Thank you.
I mean, the other one, the Russ Green at MGH is the one who's gotten a lot of press for his sort of negotiation model with the really explosive child. Now that's a little dramatic, right? But there's stuff there for the kids who are really not regulating well. But I think there's a whole cohort that the pediatric team sees who are not yet in trouble, but the parents don't know how to provide the environment optimally. That's when the parenting groups really work, right? And the issue is we're all in it together. We need some help in how to do it. My feeling is that the conscious discipline one the focus for some of them is very much on how do you discipline a child who won't listen, who won't do this, won't do that. But the good ones sort of focus on how do you interact with a child and respond to a child and, you know, impose the rules and while also doing that. Anyway, as I say, I strongly recommend looking into those. And you can try, I mean, in our setting, I mean, I'm talking about Trinidad here, where we've got some major parenting issues. We charge a little bit of money. I mean, I'm working with a disadvantaged population, so you can imagine the dynamics, but we charge a little bit per session, right? It's not like you just hand it out for free. When I say we, somebody else delivers the common sense parenting to our disadvantaged community NGO, basically.
I have a comment. Our integrated therapist was doing triple P on a one-on-one basis for many years. Do you feel like the group model as opposed to one-on-one is a much more effective for this kind of parenting education? There's a lot of logistic issues on, you know, getting groups together. You know,
I mean, I think your question is very well taken. I don't think there's a reason why you shouldn't use the principles of Triple P one-on-one. But, oh, sorry, I just got sidetracked here. Bob Michael says maybe parenting groups should be universal. Yes, Bob, you're on. Absolutely. We all need parenting 101. But you see, it seems to me that some of your pediatric, some of you, because you're pediatric teams, some of you probably are in a position to tell your parents of all the kids between 3 and 6 that we are starting a parenting group and would you like to join? I mean, we do these things at Children's and people will actually hack their way into Boston and the Children's Hospital parking situation to come. But if you're in the community and you make it say, you know, every other Saturday morning from 9 to 11, or, you know what I mean? You could do that because you are embedded in the community in a different way.
Right. I do think there's perks to doing it both individually and in a group model. I think especially with regulatory capacity, I think some parents feel a lot of shame around their children's behavior, and it's harder to be in a group model at times. Sorry, I can't move my head or I lose the mic. And so some parents do need it more one-on-one, but I think that there's a lot of power in doing group models where parents get this understanding that they are not the only ones that are struggling with this issue. A, B, the ability to share tips, strategies, other things like that. C, the ability for them to get their children together, especially if it's in a community-based model. These are often the kids who are not invited to other activities. And I think the final piece is in terms of utilization of resources, it's much harder to do on an individual basis just because there's not enough time in the day to fit in all of these visits. If you have one clinician in a larger group practice that can do 5 families at once, then that might be a more effective model than doing 5 of those families individually, especially when families need night-based services or weekend-based services or things like that. So I feel like the chat number went up, but I can't see it.
Yeah, Bob Michaels came in and said maybe parenting groups should be universal. That was my reaction. Yeah, parenting 101 would be really helpful for all of us.
Okay.
I mean, some of the ideas you've shared, I think, are wonderful. They require, you know, some investment of time and energy. But I think the thing that doesn't require an enormous amount of time and energy is just being aware, you know, kind of purposefully sort of thinking about your interactions with kids and families and thinking about how to apply some of these ideas and just making that mind shift and just changing little things that you do individually without having to set up a program or a group. I mean, really just being conscious of the tremendous opportunities you have in every interaction with a child and family to do something very positive along these lines.
Thanks, Jonah. All right.
Well, I guess everybody else got coffee and cookies or muffins, but I didn't hear my house, so I might Thank you, folks. I hope this was interesting. Please give us feedback or ask, send us questions directly if you think we could help somehow. It's been a pleasure. I hope it's not been too awkward in the webinar format. It's the first, as we said, it's the first time we've tried it in this form. So have a great day, everyone. Thank you.
And I would encourage all of you to take these ideas back and discuss them with your team, and really it's a consciousness thing. It's a thinking thing, and be creative. And see you guys all in September. Bye.
Thank you. Thank you, M. Cooney 99, who says thank you to everyone.
Oh, great.